Thank you, Andy. Welcome back, and lovely place. And welcome back again. So my topic will be therapeutic target for depression and focus on white matter. So I know most people here are quite familiar with antidepressant and psychiatry. So I just use a couple of minutes quickly go through the background of depression. So the unipolar depression is really the most challenging disease, especially in the next decade. And certainly everybody was thinking their own field will be the most important. People study diabetes, will see next decade, diabetes will be number one. And heart disease, will see heart is the most important. But for unipolar depression, we convinced is the major challenge. So quick fact about depression, and the diagnosis is depressed mood and loss of interest. And then it's quite high prevalence, lifetime around 10%. And any given time, given month, 12 months is around 5%. And each insurance company and medical care system pay huge cost attributed to mental health, and especially about workplace difficulties. There's a high mortality associated with suicide, and that's the major issue as well. So what is depression? Everybody depressed once in a while, and have to come to the state of impaired workability, poor social functioning, and psychomotor retardation, and as any other added symptoms. So problem with suicide is also a major risk for young people especially, and also for geriatric population. So how to explain depression to general population or even to any kind of patient? So we'll talk about depressive illness is clinically different from the blue and involved with chemical changes in the brain. And there's a significant cluster of symptoms and how to treat it. And we say pills for symptoms, talking for problems. So talking therapy can help resolve problem and are soluble, coping with the insoluble and examine other problem, and same unrealistic to the patient or therapist. And another part is prevention of further trouble will be considered when the treatment is coming to the end. So let's talk about neurobiology of depression, and there's not much evolution recently, and until ketamine on board, we had a few sessions already during this meeting. Biamine hypothesis still in our textbook, and all those antidepressant working on dopamine and serotonin, and recently talk about NMDA and other neurotransmitters. So those are three important neurotransmitters in the center stage for all medication available so far. And we do not have a wonder drug for our most challenging topic. From basic neuroscientists study neuroplasticity in depression is really a focus, especially talking about BDNF story. And also the neurotrophy in depression is identified from animal study and also patient study. So in depression, it results from loss of neurotrophic support that leads to atrophy, loss of neurons, and later on I'll comment about anything beyond neurons. So all the antidepressant, in part, acting on neurotrophic factors. So that's talking about neurogenesis or neuroplasticity. It's the same meaning. Anything related to stress, we need healthy stress, but stress is too much, and working with resilience, people not have enough resilience and cause depression. Certainly there's environment factors and genetic factors. So we're talking about talking therapy, and we have a different kind of schools. CBT, and right now probably people will say CBT is the most recognized with some biological basis, but we do not know the dosage and the length of the treatment for CBT in any given patient. So it's a guesswork or art. Therapy for depression beyond the pills also have a very effective treatment, ECT, but ECT is, at least in the public eyes, quite dramatic. So people use something disguised ECT, such like a TMS and deep brain stimulation. And those get popular and popular, especially for psychiatrists. We do not have many procedures to do to help the patient. Right now with RTMS, it's quite popular. So the ECT is still very important, and especially for older patient. And transcranial magnetic stimulation, we even don't know how this works. There are so many theories about this. And deep brain stimulation for selective patient. And vagus nerve stimulation, I don't think it's popular anymore with RTMS available. So in the end, as a psychiatry, probably around 80% patients come to our office, we need some medication. And medication, how effective? It's around 60%. And placebo, around 40%. But I would like to emphasize the placebo would be much lower if the medication is given by machine. But because we give medication from our office and the patient has placebo effect to psychiatrists, not necessarily to the fake antidepressant. So that's why psychiatry will never lose job. At least we are going to working on this 40% placebo effect. Beyond the medication, there are so many different kind of complementary alternative medicine, physical treatment, and Mahjong in China, square dancing, and nutraceuticals, omega-3, all those something safe but not necessarily scientifically effective, or herbal remedies, whatever work will work. So the talking about antidepressant, and for the last 50 years, not much breakthrough. Only recent about the ketamine is another very hot area. The St. John's wort, very popular in European countries, but in North America, not much so, because the major drug company, Eli Lilly and Pfizer and all those medication makers have very strong headquarters in the United States, so they might want to make sure St. John's not be a medication, will be just a healthy food in the grocery store. Melatonin, another stream of study, and certainly for sleep, pretty good, and for jet lag, and people already start to use this as an antidepressant. So we are talking about antidepressant. So in my own team, we really studied the neuroprotective effect of antidepressant, and in this case, in vitro study. And this use different antidepressant and showing neuroprotective effect to the neurotoxic effect of hydrogen peroxide. We also did animal work with the venlafaxine, and showing the venlafaxine really stimulate BDNF, at least compensate the BDNF decrease under the stress. Then we switch our focus from neuronal part of BDNF parameter to oligodendrocyte. And there's a new neuroimaging study show white matter deficiencies suffer from depression. And also in the postmortem study showing white matter deficiencies. And so far, most antidepressant, even including ECT, is enhance oligodendrocyte function or markers. So here is the density and size of oligodendrocyte is reduced in depression. This is white matter, myelin staining intensity in the human brain. So oligodendrocyte, we also all know, is like optic fiber. We need some insulate. So if they're not insulated well, the speed of transmission will be different, not synchronized. Such like in this case, there's a myelination in different insulation needs, and function of myelin is jumping the electricity with a much faster speed. So in case of myelination damage or deficiency, we can see the transmission of the signals will be compromised. In this way, people argue about different brain areas hyperactive, and most people argue a different area in the brain is hypoactive in the situation of depression. So this is functional relevance. So there's a proposal, depression and hypoconnected brain. That means white matter abnormalities is indicated in the neuropathology of depression, at least part of patient group. So our general hypothesis with myelin and oligodendrocyte dysfunction is etiological factor in the development of depression. And the stress makes it worse, and therapeutic intervention through at least partially and improving oligodendrocyte function and enhance resilience of oligodendrocyte. So we use animal models and this unpredictable chronic mild stress, and we show the dismanufacturing attenuate oligodendrocyte-related protein loss induced by stress. And we also use the animal model of demyelination. Is a very old neurotoxin. However, we use a lower dose, induce a cognitive deficit, but not sensory or motor deficit. So the quetiapine is antipsychotic, but we also use as antidepressant. And we use the animal model of cubisone, and we can see quetiapine prevented mice from cubisone-induced demyelination. Here's the pathology, and you can see the quetiapine also prevented mice cubisone-induced demyelination, and we can see clear the panel A is normal, and panel B is normal plus quetiapine, and panel C is cubisone only, and panel D is cubisone plus quetiapine. So here is a curve also showing the quetiapine promote MBP expression in the cerebral cortex or developing brain. And this way we treat animal with cubisone first and waiting for the recovery, and the quetiapine speed up the recovery curve. And also we test the working memories and also look at the cortical cell culture, look at the myelination and the quality. So in this end, we use the medication to try to emphasize white matter involvement in depression model. We also use RTMS to see if there's an impact on white matter quality or resilience. So we know RTMS treat so-called restoring the hypoactive brain, and then the RTMS working on the hippocampus area and have a different marker. We can see the TMS really stimulate. And also we use the stress-induced, so the factors decrease after 6 weeks of cubisone, and RTMS really promote the recovery. We, in addition, used RTMS. In our lab, we also use ultrasound, another method to try to manipulate or interfere with the white matter function. So you can see the ultrasound for depression already has some publication showing ultrasound change mental status. and they use CT1 chronic pain patient use ultrasound. So we talk about ultrasound and mainly create the thermal effect, but also create the vibration, so sounds like a massage for in the cellular level. So the benefit of ultrasound for neural circuits, and we see if ultrasound is really working on the pathology or etiology of the depression. So here's the box. So we develop an ultrasound stimulator working on the cell culture first in different tissues. And we develop the curve so we know how much energy the ultrasound stimulator should deliver. And then we use this learning to use for animal models and look at the neurogenesis, look at the different pathway, different kinase, and you can see the low level, the ultrasound increase viability of both neuronal-like cell and also glial cells in vitro. And then we use the animal study showing the ultrasound can reverse the restrained mice generated BDNF decrease. The tube on there is showing the mice put there, and we apply ultrasound. And we try different ultrasound dosage, and we choose the one with reasonable dose curve. Here's the experiment picture showing that we use ultrasound to give energy to the brain. We did the behavior test, and showing the ultrasound has some benefit effect in those behavior tests. So it's very exciting. We follow up with those studies and look at the white matter markers, look at neurogenesis in hippocampus, and we really convinced this ultrasound improve depression-like behavior from repeated restrained mice. And also we look at the neurogenesis and also look at the white matter pathology. So in this way, we use the CUPS model again to induce a demand-nature model, and we use ultrasound to promote the recovery. And we can see here ultrasound really have a significant effect. So the prevention of in vitro myelin and oligodendrocyte by ultrasound could attenuate the depressive-like behavior induced by cupsome. Then what is the mechanism? We don't know yet. So look at those membranes. Maybe they promote membrane fluidity, some channels configuration, and open blood-brain barrier. So we do not know that yet. Maybe they're just a pure energy deliveries. So this is a very interesting project. We want to use this way to apply to patient, and we try to do some study with our collaborators. To summary, involvement of oligodendrocyte degeneration in pathophysiology of depression. We try to argue that. And depression situation decrease in white matter volume, loss of oligodendrocyte, and also downregulate myelin-related genes. And if lesions in the white matter may be treated and use the quetiapine drug or antidepressant, and recently we use RTMS and ultrasound. So here's the one we try to figure out whenever we talk about our basic neuroscientists. They give us those maps, let us figure out. But we'll say we are a clinician. We have some problem or questions. You guys help us to figure out. So in the end, white matter is very important. And just like the networking, connectome, whatever we talk, so the white matter connection are always considered in our future diagnosis and even the drug development. Thank you very much.